Hello, everyone, and welcome to our 2024 first session of our free Q&A. Happy New Year, everyone, and thanks for joining us on this fine Thursday where a lot of you guys are probably freezing to death, and I hope that you're staying safe in all the weather that's going on in the States. It was actually freezing in Florida yesterday, went down to about 28 degrees, felt like 20. And for those of you that live in Florida, you know we are not prepared for this kind of cold. And we actually had to wear some gym socks with our flip-flops, and it was not a good look. Let's just put it that way. But we wanted to get started with some housekeeping items. And Cindy, I know that you're waiting to talk about 1860 because I think you have some information to share.
Well, thank you, Sherry, and welcome to everyone today. Those of you who participated in the live session or listened to the recording from our final session of 2023 know that we had a vigorous conversation related to OASIS item 1860 ambulation. You also may have seen in our newsletter that I put together a blog where my commitment to OASIS accuracy means that I took that question directly to CMS by submitting it through the official Q&A process. I did that right after our session, that end of November, and the email I received said that I would have an answer in 5 to 10 business days. I have since emailed 3 times. It's 6 weeks later, and I have no response. I also kind of thought maybe they were going to just put something one way or the other in the January Q&As, and any of you who've looked at that see that there's only 2 questions that were in it, and neither had anything to do with 1860. So I didn't want anyone to think that maybe I was hiding an answer, didn't follow up on an answer, and I have not been talking about the details we talked about in 1860 because I want confirmation one way or the other as well. But I just wanted to update this group that I am continuing to try. As a matter of fact, yesterday I just thought, okay, start the submission process all over again. Maybe there's something that glitched and got goofed up from the holidays. This time around, Sherry, I didn't even get the automatic acknowledgement of a response in 5 to 10 business days. So I'm not sure what's going on. I will remain diligent with this and up the chain if I have to. And as soon as we get an answer one way or the other, we'll make sure this group has the ability to access that information, and we will circle back to it at our next session. I just didn't want anyone to think we were smoke and mirrors in that, and shouldn't there have been some sort of response by now?
And the OASIS Q&As came out yesterday or day before yesterday, and we highly expected that there might be an answer in there, right?
Nope. Yep. Was not there.
It was not there. So we're, as soon as we get it, we will be sharing it on all of our platforms so folks can have that answer and they can have that clarity and understand that, you know, that's something that we're dedicated to, and we read a ton every day. So if anybody gets a resource or something that they want to share with us, please do. We definitely want to get that clarity for everyone moving forward and get it in. And Cindy, someone's asking if you can share what was asked about 1860 to CMS.
So the discussion was around a unique circumstance, and I use that word on purpose. What do we do with 1860 when we have someone who is completely independent with a walker on all surfaces in their environment? So this is not somebody who's fine with a walker intermittently, and where would that land if we, particularly at the time of discharge, have somebody who's basically can run the streets in their environment with absolutely no concern about their safety and no need for human assistance? It just happens to be with a walker instead of a cane. If we look at the current response options, we're kind of stuck because 0 reads independent, no equipment, no assistance. 1 ties it to a one-handed device going on all surfaces with no assistance. When you start getting into 2 and 3, yes, there are some old Q&A responses there, but it doesn't really address that unique situation when someone is fully independent. Because if we think about it, those response options in 1860 flow very similar to the bathing question. And the bathing question has a 0 that says you're fully independent with no equipment and no help. And a 1 says you have no help, you don't need it, you only use equipment. And it doesn't differentiate if that's a tub seat or a transfer bench or whatever is involved there. So I pose the question to say, in this unique situation, it does not appear that response 2 fits someone who's fully safe and able on all surfaces and happens to use a walker instead of a cane. And yet you seem to have tied 1 to a cane and cane alone. So I positioned that very much not as anybody who uses a walker should be a 1. Absolutely, that's not what that discussion was in our last session. But really, what do we do? Because it feels like someone who's achieved a level of being completely safe and able with a walker doesn't seem to fit a 2 talking about intermittent issues, and it doesn't read at all that this person is completely safe there on all surfaces. So it remains to be seen what we find out with that.
Okay, that was a great synopsis of a very long discussion that we had on Q&A. And anybody who wants to look at the previous Q&As that we've done, they're housed on our YouTube channel and they're free. They're free to anybody that gets on the YouTube channel, and I highly recommend that you subscribe, because when we post new stuff, you get a notification when you subscribe. And we do unfiltered podcasts, we do educational sessions, and we post our Q&As on our YouTube channel so that they're freely accessible for everyone. And I wanted to mention that we got a question from one of our listeners who had a situation with their notice of Medicare non-coverage. And it was a very good question, and we wanted to address it here. However, as we read the question, we realized that they had already reached out to the Quality Improvement Organization and had not gotten an answer. And they were looking for a reference on how to address a kind of a complicated notice of non-Medicare or Medicare non-coverage. And I'm going to recommend to folks, when you don't get those answers, and when you're looking for that reference, to make sure that you stay in compliance with those things. And sometimes they don't spell it out clear enough for you in the references and in the regulations. Make a policy that your agency follows consistently, and put a notation on that policy that when you reached out to the QIO office and that you have not received a response. If you're consistent with the policy that you set in your agency, I think that you're going to be protected for compliance. But always take that extra step and make sure that you put that notification that you did reach out to the QIO or your fiscal intermediary, be it Palmetto, be it NGA, whoever is your fiscal intermediary, to get that answer. And again, if they don't respond to you, just set a policy and follow it. Cindy, did you have anything you wanted to add on that?
Nope, you covered it well.
Okay, so are you ready to get started, Cindy?
Yes, I am.
Okay, here we go. When a patient changes insurance in the middle of a certification, we complete a discharge OASIS and then readmit them with a new start of care OASIS for insurance purposes. Is it sufficient to use the same in date, quote, in parentheses, face-to-face order?
Okay, face-to-face seems to be the topic of every moment of every day for us here at K&K in some variation. It is my understanding, and Sherry, as the coder, you can jump in if you would like to clarify or if I misspeak anything, but it's my understanding that a face-to-face, as long as it is still within the correct parameters, is used for that situation. But we also do have some situations we run into with clients where they did that payer change and the date of the face-to-face was outside of the parameters. And so that was deemed not sufficient and ultimately was denied and is currently in an appeals process. So I think it really comes down to, Sherry, the face-to-face still has to be compliant with the dates in question.
100%. And I want to encourage everybody to look at their face-to-face protocols, to look at their face-to-face processes, because face-to-face is one of the lowest hanging fruits on the denial tree. And I say that because every session or every quarter we get a report on what denials are happening. And the number one denial is always that people did not turn in the paperwork that was requested in an ADR or a TPE. They literally didn't send the information in. The second one, 99% of the time, has been non-compliant face-to-face. We have to get to a point where we accept that the face-to-face is an onerous requirement, but it's a requirement 100%. And they just released a new checklist, which I provided to folks that subscribe to our newsletter. And that checklist should be your guide for what needs to be on the face-to-face. Trying to round the corners on that compliance box is a recipe for trouble. It's a recipe for having things taken back. We do ADR assistance and TPE and RAC assistance all the time. And our specialist in that domain is she's very frustrated when she gets to the point that it's a non-compliant face-to-face, because what does she say, Cindy? There's nothing she can do to make that occur. Right?
Yeah, I mean, it's pretty much, if this is not meeting those expectations, the odds of appeal are very small. The best case scenario becomes that you attempt to appeal, hoping, ironically, to get denied again and try to flip it up to the ALJ.
Yeah, that's a scary place to be.
Mhm.
You don't want to get up to the ALJ with, no there, meaning that you didn't meet the one requirement that came in 2007 that we can't keep resisting. We just have to be compliant with it. And that's a frustrating thing. It's one of those tickets to ride, right? It's one of those tickets to be able to see one patient at a time in the home. We are the least supervised area of care in that we have one person in front of a person without anybody else watching. And so there's a lot of onerous requirements that occur for home health to make sure that we actually are seeing patients that are appropriate and that patients that are under the care of a physician. So I think it's one of those things, Cindy, when you deal with your kids, you just say, hey, life's not fair. We have to do it. And it kind of stinks, but yeah, we have to do it. Another scenario kind of came up in my mind when this came up, and I wanted to add it as one question 1A. Okay. If a patient comes to you and you admit them on day 1 and they are rehospitalized on day 4 and come back on day 7, is it appropriate to discharge them and readmit them on day 7 as a new patient? And if you do that, what should you do with that first visit, or maybe first 2 visits if you have another discipline in there that occurred prior to the hospitalization?
So realistically, Sherry, any transfer to an inpatient facility like that, an agency has an option with respect to completing that transfer, to transfer and leave that open with the anticipation of doing a rock, or transfer with the discharge, and then ultimately you're going to be readmitting them. But the bottom line is you admitted them, you provided care prior to their hospitalization. So I understand for some folks it can be frustrating to say, well, there was only one visit, and what if they don't come back, and those kinds of things. And I'm sure, Sherry, of the about 100 people we have on here right now, some are scratching their head going, well, obviously what you would do, you do a transfer and then you readmit them. But we have run into some issues where agencies are deciding that the paperwork involved with that 1 or 2 visit initially is just not, quote, worth dealing with. And so they are basically converting that initial start of care into a non-admit, even though a visit or 2 has occurred already, basically removing it from existence and then making it a fresh start of care when they return. Obviously, and I can feel some of you, your eye twitch, or you're like, what did she just say? Yeah, that's an interesting thing being in the consulting space, is that we share examples not to, make anybody feel bad or weird, but to remind ourselves compliance requires diligence. And we have to make sure that some things that sound like they might be a quick fix for something or easier, or, okay, I can understand that. We always have to make sure, are there rules that govern that? And are there things that, as Sherry said about the face-to-face itself, yeah, it's onerous, yeah, it's annoying, but I need to make sure I'm not cutting off, if you said many times, Sherry, trying to turn that cube into a ball by cutting off those corners. So the idea that I would just pretend I never admitted you and start clean is really not the way we're supposed to do it. It would be to do the transfer option, and at the agency's discretion, it's a discharge or wait and resume them.
This did occur in our consulting area, and we had someone who was using that practice of not admitting them, calling it not taking under care in tuck. Everybody knows what that is, and bringing them back as a brand new start of care, and never billing that first encounter or however many encounters occurred before that patient was hospitalized. And I want to think about the name of the sitcom back. It's a black and white sitcom, Danger, Danger, Will Robinson, Danger, Danger.
Lost in Space.
Lost in Space. Thank you. One of the things that we as Medicare providers, we have to stay within the guidelines of Stark, and we have to stay within the guidelines of incentive. And we cannot provide anything of a value more than $75 to a Medicare recipient. That we just can't. We're not allowed to. That's considered an incentive. And a visit in home care has a LUPA value that exceeds $75. And so if you do that practice, yes, would it make your rehospitalization look a little bit better? Possibly. Could it take down some of your paperwork burden? For sure. But is it an incentive, and does it get into danger territory as far as providing something over the cost of $75? Absolutely it does. And so I would definitely caution that practice if you do that in your agency. And this is one of those public service announcements, right, Cindy? So don't go there. Do the admission, take the LUPA, and then readmit them if that's going to be your procedure, or transfer and readmit with a rock. That's the only way to go in those situations. So if there's any questions on that, please feel free to reach out to us, and please feel free to type any questions that might be coming up during this session into our chat box. Now that we're on this Zoom platform, things have changed a bit, and I want to thank you guys for coming along with us with this change, and hopefully it won't be too much of a trouble, and everybody will get the recording and everything will be great, and we can move on and go forward. So Cindy, you ready for question number 2?
Yes.
Okay, when answering M1830 bathing versus GG0130E shower/bathe self, if a patient only requires setup, cleanup for scores 0, 5 and GG question, which would be the appropriate selection for M1830? Clinician chose M1830 as a 3.
Okay, so we have to remember that when we're looking at 1830 versus its GG equivalent, it is one of those questions where the parameters are different between those two. So we know that in 1830, the act of transferring in and out of the tub shower is included in our assessment of their ability. In the GG counterpart, it specifically excludes the transfer in or out. And so if someone's choosing a response of 5 indicating setup or cleanup, that could be encompassing that transfer element, that the issue is once they're placed within that tub shower, then assistance is no longer necessary. And we have to keep that in mind if we're going to defend a 5 and say it's because my setup was putting you in the shower, that's fine. But with a 5, I've said I helped you in and I vacated the building. I don't need to help you. I have no concerns about you. The only thing was setting you up to do this bathing activity, but I'm not in the room. I don't care. I'm not worried. I have no concerns at all. That's what a 5 is. The only thing I'm doing is set up or clean up in any of the GGs. The act itself is still being completed, completely safe and able. So if that's what I'm saying, all I did was put you in and leave. Okay, a 5 would fit there for bathing. But then when I go back over to 1830, the transfer is part of it. So if I'm going to defend that all I did was help you get in or out, then we can see by the way the responses are worded, the best response is in fact response 2, because it refers to the need for intermittent assistance. And it does list examples within there of things that are considered difficult to reach places, so on and so forth. So if that's strictly it, then it would be response 2. Now, the reason I'm choosing my words very carefully about dying on hills and strictly is as I review records, sometimes what I see is there's a 3 over in 1830, as our question asker described, and in GG it's a 5. Sometimes in the conversation with the clinician, it isn't the 1830 that's wrong, it's the GG that may not be scored correctly. So to understand that if we're saying it's truly just intermittent help and it's just that setup piece, then it would be a GG of 5 and an 1830 of 2. But if we pursue this further as to why did you pick a 3 in 1830? Well, I thought they should be supervised for this, or it was more than just the transfer. Then we would want them to go back and revisit their choice of 5 in the GG, because that may not be the best response to capture what's going on.
Thank you so much for that. And that brings us to our second slide. We have developed a webinar that is going to be a live webinar that will include Q&A about leaping into the GG items and the changes that are going to occur in 2025. We've got notification that there's a new version of OASIS coming in, and I'm going to use that as question 3, Cindy. What are the anticipated changes in OASIS E1 in 2025? And folks, if you want to join us on that webinar on Leap Day, because it is leap year, you can use the QR code or the website address that's on here to pay for 1 user seat for your entire agency to use. It's very reasonably priced, and we hope that you can join us on the 29th. But Cindy, what are the anticipated changes in OASIS E1 in 2025?
Well, I think we can tie this into 50% of the January Q&A, since there was only 2 questions, because the first question very much falls in line with this. With respect to what was asked in the Q&As, was that, the final rule did talk about changes that needed to happen to the OASIS and ended up in the final rule. So the removal of episode timing, the removal of putting any therapy visits in there, and ultimately the removal of the GG goals column all became finalized. So the question was asking at that time, does this mean there's going to be a new OASIS? And the question asker referred to it as OASIS F. And I kind of chuckled. I'm like, no. We don't want a letter change. Anybody who's been around this a while knows we don't want letter changes. Letter changes mean you've done some major overhaul. If you're talking about doing some cleanup, well, that typically is how we end up with a dash and a number. So that's why what we see coming in 2025 is OASIS E1. They released the document itself earlier this month. They have not released the guidance. And that's where we go, okay, so what do I need to do? Do I need to do all this education? Am I going to have to plan? Any of you know me, I try very hard not to be a fear monger when it comes to OASIS or any other regulation issues unless it's absolutely necessary. And I don't believe here that it is. The reality of the changes, first and foremost, we want to see the guidance manual. Why? Because there's a new question. They're adding a question simply because they said they wanted to start a process measure related to COVID vaccines. So if you want to see what the question looks like, you can look at the current document that's available. But if you're like me, you go, yep, I've seen OASIS questions before, and I read the English language, and I think I understand it. And then the guidance comes out and goes, what? A peanut allergy factors in on this other thing? Well, okay. So I have a healthy degree of skepticism at this point that when it comes to that question, I'm going to wait and see until we have some sort of guidance out there, and then we can say, okay, what does this really mean? Get my staff up to speed. As far as removing the episode timing, early versus late, and the therapy number, some of us have been going, why didn't that fall out in the conversion to E? Because those two are residual issues related to PDGM. And so it's like, not PDGM, the prior payment system. When we went to PDGM, it was like, okay, they let the questions linger for a little bit. Yes, episode timing is a piece of information, but they no longer collect it from OASIS. They take it from claims data. And the therapy visit thing stopped counting under the Medicare payment methodology in 2020. So this just seems like a delayed, inevitable, please make those go away if they're not being used for anything. They left them in there for a period of time in case there were still some payers using a PPS equivalent that wanted those 2 pieces of information for a calculation. But that is now expired and those 2 will go. The remaining piece is the removal of the goals column in the GGs, GG 130 and GG 170. Now that raises some interesting questions, and we're going to cover that in a bit more detail on that webinar on the 29th. But the issue is that the GG items are going to be a subset of them, not all of them, pulled into the value-based purchasing methodology. And as such, they have deemed it, because they're going to create the model that is currently in place in skilled nursing facilities and other levels of post-acute care, where they're going to take our baseline responses, run them through magic math and projection, and give us the predicted scores at discharge. They're not interested anymore in what we put down in that goals column. It's going to be calculated for us that makes that whole column of goals basically not useful, or if it's not used for anything, they're going to take it out. So again, that sounds like, well, just what you said about episode timing and therapy visits, just, oh, it's gone away. Yay, it's gone. Okay, but some have already posed to CMS, hey, if you're going to get rid of the goals column in GGs, does that mean we can just kind of start skipping them now? I mean, if it's going to go away in 2025, can I just ignore it? Maybe not review it, maybe just put whatever answers you want, it doesn't matter. CMS has been very clear, and that does re-echo in the Q&As, that they do expect us to follow the guidance for all 3 of those issues, episode timing, therapy visits, and that, until January 1, 2025. So we want to make sure that we don't see this as just put whatever you want in the goals column, because we know that between now and the end of the year, that data is still being submitted to CMS. And my biggest concern this entire time that it's been available is there seems to be a tendency for clinicians to put all sixes in everything for everybody. As if, yep, I'm just going to tell CMS, I think I can make everybody independent in every single thing listed in these GG items. Now, for some patients, that's absolutely true, and I think that's great, and I'm glad you put that down as the goal. But we have to be careful that we're not creating artificial expectations. So I think in the interim, it's still important that we're looking at that from a review process. If we see trends toward it's always the same answer or it's always independent, we may want to continue to work with our clinicians about setting realistic expectations. For patients that aren't going to improve in something, it's perfectly fine to put the exact same score number at discharge. And if you realistically believe they're going to be worse than that by the time we're done due to disease process and other things going on, put a level lower than that. The instructions have said that since we started. But we just want to make sure we're not going to create some sort of free-for-all that says, well, if that's going away on E1, then I don't really care about it now, put whatever you want. We want to make sure that we're following the guidance and providing accurate information up until December 31st. The only other thing, Sherry, is you can tell when you look at the new document that some of the copyright issues around things like the BIMS, the CAM, there's just some updating, it looks like, to that language, because we know that any of these questions that they took entirely or in part from other tools, they were legally required to put that copyright information directly on the tool. So friendly reminder to this group, if you're doing any education in your organization, you have to make sure that that same copyright language remains with the question. That was a much earlier Q&A last year where CMS confirmed that that language is part of the question. So it has to be present in the EMR, and I would say by extension should be present in your education, so that clinicians are always looking consistently at the question in its entirety.
And Cindy, I just want to, for a moment, talk about the big picture with the GG items and why they're changing. The GG items are part of the Impact Act of 2014. So here we are 10 years later, and they're using the GG items in the hospital stay, in the IRF, in the skilled nursing, and at home. And if you really want to get us riled up, we can talk about some of the measurements that they're using in the GG items in the home and how they are so technically and realistically different than they are in facilities. Cindy and I had a long discussion, I want to say a day ago, about how it's really tough to compare a hospital rolling and sitting up on the side of the bed in a fully hospital based scenario with a hospital bed and what we see in many of the homes. And those two things really are not comparable. So there's going to be adjustments made. And we're going to be fighting for that. And I hope that you're fighting for that as well, so that the items that are used as part of the Impact Act, which is a law, are more realistic for the home health setting, because the home health setting is uniquely positioned compared to those other facility-based settings. And Cindy, you said you had another question that was typed in, and do you mind putting it in the chat?
Oh gosh, you're going to ask me to walk and chew gum at the same time? It's lengthy question, but I can kind of summarize that here, Sherry. I don't want to technically start messing up the chat box. The question is with respect to the BIMS, and this individual has also submitted their question to CMS last month, so we'll wait and see if this ends up in a Q&A in the future. The scenario is at the start of the interview, and the clinician has established that the BIMS can continue since the patient is able to communicate. When asked by the clinician to recall 3 words, a patient requests to write the 3 words down on a piece of paper. The issue is that acceptable? And I think it's, again, that's an important question to clarify with CMS, because we know that when you look in the guidance, it talks about individuals that cannot communicate effectively verbally. We can use cue cards with respect to 3 words and the different questions and those kinds of things. But in the scenario as described, my concern would be writing them down. You also cannot have them there so that when I ask you what they are later, they have the opportunity to read it off that same piece of paper, because that's not recall. And they may be very used to writing things down as memory devices, which is great. If that's what they use, that's something we definitely want to capitalize on from a patient education standpoint, whether it's medication or restrictions or disease management or safety issues, that's a great thing to know. But we can't use it if the patient is going to try to then read it later off that same sheet, because then that's not actual recall. That's the ability to read it off of a piece of paper later. So I think we're walking a fine line there of, yes, it does talk in the current guidance about being able to present the words in writing. But again, it couldn't be used as let them keep that piece of paper and come back and read it to you when you circle back to those 3 words at a later point. So again, I commend anyone and everyone. When in doubt, we can submit, and then we have to share that resource when we get it. But I would say, speaking to the immediate issue, if that's really just the patient wants to read it back to you later off that same piece of paper, then it does not appear to be the intent of measuring their ability to recall 3 words.
Okay, that makes complete sense to me. Someone who doesn't do the OASIS and has questions about that when I'm doing reviews all the time. So thank you for that, Cindy. That to me is a timely one. I wanted to mention that we got a question about billing, and that billing question had to do with the negative pressure therapy in home care. Negative pressure therapy is often it's often called wound vac. There's many providers of wound vacs, and in outpatient settings, they've always been paid for via a CPT or a HCPCS code. Well, there is a code now for home health, and that code is A9272. And you should be using these codes on your final billing, or on your 30-day and your final billing, I should say, whenever you replace a disposable wound vac device. If you're not using disposable devices, then you're using the same suction mechanism each time you dress the wound. There could be a code for that non-disposable. I was looking for that this morning and I could not find it, but this code A9272 has to do with the disposable ones, and the charges on that should be each time you change the disposable unit. My understanding and everything that I've read is that disposable units cannot be reused. Every time you have to change the wound vac, which might be every 3 or 4 visits, you have to go in and put in a new disposable unit, and you have to make that charge reflective of what the former CPT and HCPCS code was for outpatient. And from what I could tell, that was around $35 an incident. I would make that charge higher because Medicare will pay you for the lesser of the appropriate amount. So whatever the appropriate amount is, you never want to bill less than that. You always want to have your fee schedule a little bit higher than that. So my recommendation would be that you look at what the CPT codes pay for that in your area, those old outpatient codes, and then reflect that in your fee schedule when you put it in. And Cindy, this one's super important because we had a supply add-on at one point in our reimbursement. You remember that?
Mm-hmm.
Interesting thing about that supply add-on, it was a code at the end of your HIPS code that said whether or not you anticipated that patient was going to need supplies. And depending on the diagnoses that preceded it, depending on what was in your diagnosis list, would tell you how much of an add-on payment you would get for supplying regular supplies or non-bundled supplies in home health. It almost was never used. And I say that a lot of agencies, most agencies, never put the supply costs on their claims. And so guess what happened to that? It's no longer. CMS took that charge away, and they took that reimbursement away because it was not used effectively in our industry. Super important that we use the codes they give us when they add new billing procedures so that we can continue to be paid for them in the future. And someone just put in, I could swear I just read something regarding the disposable units that CMS had withdrawn the extra pay for changing those units. I will try and find it. They did withdraw the permanent one that I read this morning, but it's the disposable ones that they're paying for each time you have to change them. And again, we're talking about $30 to $35. That's not a lot. But it is a lot when you talk about a code that could potentially go away, or if you have somebody that has multiple wounds that's using multiple disposable units, that can defray a lot of costs that you have as an agency in purchasing those things prior to giving them to your patient. So I would definitely look into this and make sure that your billing service or your biller is aware of this, and make sure that it shows up on your claims so that we don't lose the ability to bill for these. Cindy, did you have anything to add to that?
No.
Okay, I would like to take this opportunity to remind folks that we will answer questions as they come into the QA. So if you have anything or into the chat box, if you have anything that's top of mind or a myth you're trying to bust or an argument you're having in your agency, please type it in so we don't miss it this time. We've got about 20 minutes left in this session and just wanted to give you the opportunity to put it into the chat box. You will be getting a recording of this when we're finished, and you're free to use it in your agency as you need to. Okay, Cindy, another Oasis question. Are you ready?
I think we get more Oasis questions in these every other month Q&A than apparently CMS gets for their official Q&A response.
I wonder if we should just submitting these as part of the I mean,
Maybe.
that might be something going forward that we should do. Okay, looking for guidance for Oasis in 2410 and in 2420. When you have a patient that discharges from home health directly to an inpatient hospice, we have a home palliative nursing program through our home health agency, and this occurs occasionally. The Oasis guidance is not clear how to answer this for inpatient hospital admission.
What I've seen in response to that is that we treat it as an inpatient admission. The key word there is a hospice. It's an inpatient hospice. And so that transfer would fall under the inpatient situation. And so we would proceed as if, it was going to any other inpatient facility and answer those two questions accordingly.
So again, the key word is inpatient.
Mhm.
And again, if it's not clear in the guidance, make sure that you create a policy in your agency that can clarify it for your clinicians, but also protect you under audit and put in there that you're not getting the guidance and when you sought it. So make sure that you put those notations into your policies and procedures, and all of that just it gives a breadcrumb trail for any auditor to come in and see how much you've worked on a question before you made a policy.
And if I can add to that, Sherry, those two questions aren't necessarily the best example of what I'm about to say, but what you just said there triggered it. I think we have to remind ourselves periodically, and our clinicians and our review team, that very often with Oasis, we are picking the best possible answer, not necessarily the quote right answer. I think when we've tried to create this, it's so black and white, the answers are right or else you were wrong, doesn't reflect a lot of the way these questions work. We're given limited numbers of response options. And so we may find ourselves in situations where it is not crystal clear. And many of you may have heard me in Oasis training situations. I swear I'm going to end up with this on my tombstone or tattooed on me somewhere. Sometimes the correct answer is 2.5. And so understanding that there's times where I'm in a situation where it isn't a crystal clear path to one answer, then I have to be able to weigh the ones I do have and pick the one that fits the best and document accordingly. I think sometimes, especially at the clinician level, with the review process in place, it projects this idea that if they pick a different answer, they're wrong. Sometimes it's simply that they're less right. We only have 4 options. We only have 8 options, whatever the options may be. We still have patients that don't cleanly fit into those. We even see that in the pain questions when the guidance tells us if the patient can't land on the difference between 2 response options, it says to go ahead and take the one that indicates a higher level of interference. So I just like to say that because I think sometimes we become hyper vigilant and we do need to make sure we're compliant and not get freewheeling with the guidance. But sometimes it's going to be, okay, as I await to get some sort of other answer, this is my thought process. This is what we're documenting. This is what I understand from the most current information. And based on that, if I wheeled it down to these 2, we're going to go with this as the answer until we hear differently. So it doesn't take away from that. I just think sometimes when we make it seem like to the clinician that other answer they picked was wrong. I mean, sometimes it is way off, and then we have to have a conversation about understanding it. But sometimes it's really, you wheedled it down to these 2. This is a unique patient situation. We're going to go with this one.
And Cindy, I just changed the slide because I think that, when I asked for questions about debates in agencies, I've gotten a few, which is kind of cool. And I wanted to give everybody the opportunity to know that we have opened a home health leadership community. It's only $99 for the year, and you get to interact with other leaders at different levels and other agencies. It's a non-competitive environment. It's a way to improve your leadership acumen and give you resources as a leader in home health, because it is a very challenging position to be in leadership and home health. And so we open this as a service to help folks that are moving into those positions. Maybe you've been in a leadership position in home health for decades. So it's a good thing to help fill your cup, because your cup is emptied on your folks in your agency and patients and everything every day in agencies as you work as a leader. This is a chance for you to fill your cup and improve your leadership strategies to the point that they can maybe cause you less stress and discord and give you a little bit more comfort in how you lead folks in an agency in these challenging times. So take this opportunity and become a member, and you can play along as much as you want, but you can be a silent observer if that would work for you. It doesn't matter, but it's definitely a communication or a community of peers and peers that want to help each other. So I have one from Annette Mays, one of our favorite people, Cindy. I'm asking for one of our agency members. We have received 2 non-affirmations from RCD because of this. This is in Oklahoma, I believe. On the face-to-face, that both diagnoses were not listed on the face-to-face, that they ended up asking for the affirmation with. This is a common thing, everyone. The patient was referred on the face-to-face for follow-up to the elevated blood pressure. And they coded it as I-12.9, and then they used the kidney disease code after that, because I-12.9 is hypertensive chronic kidney disease with stage 1 through 4 kidney disease, or chronic kidney disease. And they're getting non-affirmations because it doesn't match what the face-to-face said, which is potentially, it said I-10, which is the general hypertension code. And they followed coding guidance, but yet they're getting these non-affirmations. And as the coder in our group here, Cindy, I'd like to say, this is an ongoing issue. As a coder, you have conventions and rules that you have to follow. And in the presence of chronic kidney disease, you have to use an I-12 code to properly report that. If it doesn't match the face-to-face, the easiest fix, and I say easiest with quotations, is to get a new face-to-face. And everybody just kind of groaned. I think I heard them, even though they're all muted. Face-to-faces can be challenging to get, but that is actually the quickest and easiest fix. The second thing is to appeal it. And if you appeal it, you want to have them understand and send them the guidance that states that that's the code that you have to use. There is some backroom talking going on about this being something that needs to be fixed on the RCD challenge side, because you cannot, there's a conflicting message. You're asked to code something that's not appropriate, and then you get denied because it didn't say exactly that on the form. I would use the language to my referring sources. I would say, we are required to code as per this, because you know what? They also have to code. They have to code CPT and HCPCS claims, and they constantly have to find the right nomenclature and all the things that fit that patient. So they should understand the dilemma that home healths are in when they come to these affirmations. So that would be my recommendation. And just understand that this is being worked on at the higher levels in the coding center, and AHIMA and all of those guys are involved trying to convince CMS that they need to inform the RCD reviewers better when it comes to these coding conventions. So it is a challenge. Go ahead, Sin.
I'm just going to say, as the non-coder, where could I find language that indicates that that is following the coding rules? Because that's really what it's coming down to, is the coders following the coding rules, and then it's not aligning with the way RCD is expecting to see it. And it's an impasse that, yeah, they're discussing it, but if I'm going to try to appeal it, where do I find that actual source? Not that I just put down that that's what the coder has to do. Because the coder's not making that up.
No, they're not. I would use the ICD-10 coding manual. Each code has explanation of how it's supposed to use, and under I-12.9, it explains how that's related to chronic kidney disease. So there is an online version of that. It's called the Online Coding Center. I would copy and paste that language into my affirmation request, and ahead of time with the face-to-face to explain why you chose a different code than what might appear on the referral documentation or on the face-to-face. So if it comes, the face-to-face comes over with I-10 and they have chronic kidney disease, and so you have to change that to I-12.9, use that guidance that says that's connected to the chronic kidney disease. Basically map it out for them. Give them that treasure chest of why you chose that and why it's appropriate. I'm not in any way saying that that's going to make it successful for an affirmation, because like I said, it is an ongoing debate and how this is going to be fixed. But the general rule of thumb is the way to fix it is to get a new face-to-face that reflects the appropriate code. If in the presence of not being able to do that, I would definitely use the communication of why that code was used. Okay. Another debate in our agency. A patient is on service, goes to the hospital. Do you have to have home health orders from referring facility to resume home health? Or is the patient already on service? Therefore, resumption orders only need to come from and go to the plan of care physician.
Go ahead, Sherry.
They had a new encounter. They had a new encounter that caused them to have to go to a higher level of care. My recommendation, and I'm not sure I can find the regulation of this, is that you get the order from the discharging physician at the hospital to resume care. And they may only put resume care. And at that point in time, you can go back to your plan of care physician and work through the communication with them. But more than likely, you're going to be the point that's going to let the referring physician know that they even went to the hospital. Oftentimes that communication is delayed going to the primary care physician, and you may be the communicator between the hospital and the primary care physician. So I would definitely not resume care without a discharge order stating to resume home health. And then from there, go to your referring, and you be the one that informs your primary care, your referral, your plan of care physician to that care that's going to resume again.
So if I could interject, Sherry, I think anytime something connects to physician orders, whether it's the resumption order, whether it's face-to-face, the referral information, updating a plan of care, the plan of care itself, I fully appreciate the frustration it can be about trying to get physicians to sign these things, physicians taking ownership of this plan of care, just kind of, well, do whatever, and not being very directive in terms of what we need done. And I think that it creates a situation where we look for, is there an easier way? Can we be innovative, and can we bypass some of this? Can we make a workaround that expedites this for all concerned, especially when typically messed up orders in some capacity, the agency is going to take the hit. The physician who doesn't sign the plan of care, the physician who gives me a lousy face-to-face does not get a financial penalty from that. I do. And I appreciate innovation. And I think a lot of times just asking that question, do we need that kind of order, is worth the discussion. To look at it and say, is there a better way? Is there a different way? I never want us to always just do it because, we've always done this and we know it's a rule. We got to periodically look at the rules. Have there been any updates to this? Is this within the parameters of that? But we always have to have the guardrail of, I can't cut that corner. And I think it's sometimes with orders, the frustration is the process. If we take a step back and say, okay, this person had an event significant enough that they ended up in an inpatient facility. So yeah, I may be the clinician who says, gosh, this has happened like 3 times before. I'm going to go out and do this resumption. It's going to be exactly what it was before we go in, blah, 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 blah. I get it, but we were not there during that time in the inpatient facility. And from a patient safety perspective and our own safety, I would want to see a specific directive order to resume home care. What for? And yes, we can go through our processes to clarify that and the follow-up position and all of that. But taking all the regulation out of it, I would be extremely hesitant to take somebody without an actual resumption of care order from a safety perspective.
And I think about that with a medication complication. If a patient had a medication that caused them to go to the hospital and they come back out and we resume care without any guidance from the inpatient physician, we could be causing harm, and that could be a troublesome place to be. And so I really encourage folks to be that conduit of communication and use your marketing staff, use your patient care liaisons, the folks that go out and communicate with your referral sources. They oftentimes have a hard time getting into hospitals. Use this as the reason they can go in and talk to discharge planners and get the paperwork that you need to resume that patient. Oftentimes they come back from the hospital with a change in their diagnoses. Either they had a procedure done or something new occurred and they had to have, another disease process. And when they come out, their focus of care or their plan of care changes dramatically. And in a new patient, you always know you have to have that order to start care. think about it the same way as resuming care. And Cindy, you have another question?
Yeah, it relates to this because there's a question about, is it still non-required to submit an OASIS for one visit in the quality episode? So I go out there and that would be a PT situation because we know that a single nursing visit does not qualify this person for home care. But let's say it was a PT admit, I go out there, I've done my full assessment. I believe there's absolutely no reason to continue care for this individual. I have done one visit. I have completed this OASIS situation. Those situations are not submitted. I don't put that in there. The other thing is, though, that the question goes on to say, if so, can you explain more how this relates to the start of care being not taken under care after readmission if only one visit was made? I think we're going back to what we talked about at the very beginning. So if I go out there and I do this one visit, and the issue is let me try to think of the correct words here. The requirement to submit is if I go out and do one visit and I fully intended to do more, this person was transferred to an inpatient facility, came back to me, and I restarted care. Well, if I have continued this, then I have done this, and this is still an ongoing episode of care, then I would be submitting that and subsequent assessments. What we were talking about before was I admitted this patient. I intend to provide additional care. I provided one or two visits following that start of care. So that's OASIS should have been submitted. This was not a single visit issue. I was providing care with the intent of doing it for an episode. The patient goes in the hospital after those first few visits. I decide to pull back the notice of admission, to pull back my start of care OASIS, to convert all of that now to a not taken under care, so that when the person comes back, this is a start of care without that preceding piece of information. Some of you know exactly what the motivation would be here. That is to control readmission rates. Because if I convert those 2-3 visits into, whoa, I'm not submitting them at all, then that admission does not count for me because I'm pretending that I did not take them until they came out this second time from the hospital and then they initiated home care. So this is not about a single visit and do I have to submit it? Submission rules still apply. It's a concern that some agencies that are reporting higher star ratings, and we saw that with respect to one of the recent reports from MedPAC about reporting falls with major injury, and it seems that it's reported less often in agencies that have higher stars. But this seems to be a strategy some are considering and some are doing to reduce rehospitalization rates, which we know is incredibly problematic. So this is not about the submission rule. We do not have to submit technically if it's one visit and one visit only. There's nothing to measure. There's not going to be another time point by which we can assess quality. But that shouldn't be confused with what we talked about at the very beginning of our time together.
And Cindy, I think that's, we're hearing about these corners being cut and these games being played, and this is just a road to nowhere. It's a road to bad intentions cause bad consequences. And I think that we need to be really careful as an industry of these becoming part of our practice, because we heard of this really cool way that we could improve some of our star ratings. I think that we need to, put what we see in that patient, put it appropriately, let it reflect what the patient is in the most accurate way that we can, so that we can avoid some of those audits. Some of the folks on this call have probably been down the audit road where you started with a TPE, turned into an ADR, turned into a RAC, turned into a ZPIC, and that could be very, very expensive, not just in the money that they recoup, but also in the time it takes to fight those things. Agencies can be grinded to a halt in providing care because of the paperwork requirements when you get into those audit situations. And I know that many of you feel very comfortable because you've never been in those audit situations. Trust me, you don't want to be. So do everything you can to avoid it, or if you do get an audit, that you answer it appropriately so they don't start looking and digging for more reimbursement to claw back from you. Last question, and I love that it's on face-to-face, because face-to-face is going to be on our center person. Her name is Jackie Curry, and she is our contract coordinator, and it's going to be on her tombstone, valid face-to-face. Please advise what the guidance is for face-to-face on a patient having a new start of care due to insurance changes when the original face-to-face from the previous episode is over 90 days prior. Cindy, do you want me to take this one or do you want it?
We touched on it at the beginning, with respect to if it's outside the parameters, then we do need to get another one specific to this change in payer, because we are changing it in the episode. And typically that payer change is from a private insurance, for which Medicare was not really looking at that anyway, to a Medicare as the payer. And so absolutely they'd be looking for a face-to-face that was in that 90 days prior or 30 days after. So it may have been a face-to-face that was working for that original start of care, but now I'm creating a new start of care date. And so that face-to-face still has to fall in that range. So 90 days prior to that and a payer change, oh, okay, it's a fairly new patient. I haven't had them that long. Odds are that that face-to-face is going to fall within the 90 days prior. Where people seem to have the problem, Sherry, is a patient that's been possibly on service and restarted numerous times now has a payer change. And it's like, yeah, you're creating a new start of care and that face-to-face is 6 months old. Now you're going to have to take care of it and get an updated one, because we're seeing that end up as part of the denial process for agencies.
And I don't think agencies take advantage of the 30 days after like they should. And in a situation where you get a 90-day-old face-to-face from a visit that occurred 3 months prior to that patient coming to home health, the chances of that face-to-face applying appropriately to the current reason that you're going to be providing home health are pretty slim. And so giving you that 30 days after to schedule an appointment with the provider so that you can get a face-to-face that accurately reflects the reason why you're providing home health now is such a gift from CMS. And I say that nobody thinks of it face-to-face and gift in the same sentence, right? But they do give you that opportunity to get a face-to-face that's appropriate for that care and make sure that their physician is involved in the direction of that care in a real way. And so using that 30 days after the start of care and, using home visiting physicians, using the mid-level providers in the states that you can, all of those things are to the advantage of the agency. We just need to make sure that we're tracking that appropriately and making sure that that compliance, again, don't round those corners on that box, because it's the very first thing they look for when they review a chart.
Well, and Sherry, if I can just briefly reiterate that 30-day after, particularly on community-based referrals, I think clinicians are not aware that if what they're seeing in the home does not align with what they've been given as the face-to-face or the primary reason for referral, I mean, it really doesn't align. But facilitating a return trip to the doctor to get an updated face-to-face is not just a compliance issue, it's a patient care issue. Because if what I'm finding is not what this says, then I really shouldn't be just putting it arbitrarily down as the focus of care to get the form complete and get this record reviewed and get me through the review process unscathed. Because my plan of care really should reflect and mirror what I said is the primary reason. And so when we audit records and, oh, looky there, the focus of care and the narrative does match the face-to-face, but then you look at the plan of care and go, clearly that's not the focus of care. Or maybe the plan of care does line up, but then you start reading the visits afterwards and go, great, so you made everything look right between the face-to-face, the start of care and the plan of care, but now everybody went out and delivered the care talking about something else. And that's where we also see people get denial issues, because it's like, yeah, you made it look all pretty at the beginning, but then your clinicians went out and did what really needed to be done based on what was really going on with the patient, and it looks nothing like what you put in here. So we got to make sure that clinician understands this is not a quote coding issue that has nothing to do with me. It's if I clearly see a discrepancy, that 30-day after can be the best way to go, okay, if we're not going to be able to take care of this in terms of going back on the referral process, maybe we need to help them coordinate going back to see their doctor.
And you should have an expectation that your coding staff and your QA staff are giving you this guidance on these ones that don't match in a real way, in real time, in a timely fashion, so that you don't lose that 30-day after and be able to get it right. So the final slide has contact information for Cindy and I. If you have any additional questions after we finish, We're 2 minutes over time, Cindy, so I'm going to go real quick. Please reach out to us. You can also reference our website. And if you, again, if you have any questions that you want to have included in the March session, please let us know. And I have not set the date yet for the March session. As I'm reading this, I'm actually aware that I did not set the date, but it will be out in when I send out the recording of this session. So thank you so much for coming along on this journey today. And we really appreciate you, and we appreciate your attention and your time. Cindy, do you have any closing thoughts before we go?
No, I just appreciate people spending time with us, and we never claim to know every answer to every question. So if you ever hear something and go, wait a minute, I saw something else, that does not upset us whatsoever. Please, we need to have good conversation and make sure everything is following real rules and real guidance and not outdated ones or myths or something we heard once in band camp. But we're open to that dialogue. We do not claim perfection, and we welcome that kind of exchange to make sure everybody gets the information that they need.
And thank you all for the service you provide the folks in your communities, and please be safe out there in this bad weather. Have a great day.